I want to welcome you to the first of a ongoing series of webinars put on by Primary Spine Provider Network, Spine Care Partners, Spine Care South Africa, and our new digital platform, Spine Cloud International. Spine Cloud International is going to become our digital world for spine care with a new way to have knowledge acquisition and networking for those interested in the field of spine care. Our mission as an organization is to change the very nature and structure of the way spine care is delivered, moving much more towards a value-based model of care. And we're doing this worldwide. We are already affiliated with an organization in South Africa, another in Australia, and hopefully the next will be in the UK. With that said, let's get started on this afternoon's presentation. It should take us just about a half an hour to 40 minutes, and we'll leave time at the end, the last 10 minutes or so, for questions. Just as a point of information, there should be on your control panel for the webinar a section where you can actually click on to type in a question, and it will come directly to me, and then I'll be able to answer it. So feel free to ask anything during the course of this presentation. I'll also be doing a couple of polls during this presentation to just get your thoughts and ideas about what we're talking about. And there is a handout that hopefully will come to each of you through the control panel. It is a link to the article about the primary spine provider. So through the question section, if you would, let me know if you did not get that handout. And I'll begin here. And these are disclosures and conflicts of interest for myself. I am an owner, as I mentioned, of Spine Care Partners, Primary Spine Provider Network, and Spine Cloud International. I participate in 3 national initiatives that are interested in improving musculoskeletal care. I'm on the National Quality Forum, the United States Bone and Joint Initiative, and I sit on a technical expert panel for the Center for Medicare and Medicaid Services. I am a member of the American Chiropractic Association, the New York State Chiropractic Association, the American Public Health Association, and North American Spine Society. I spent 30 years in clinical practice, in private clinical practice full-time, and 17 of those years I was a clinical instructor in the Department of Family Medicine at the University of Rochester's School of Medicine. And for about 15 or 16 years, I was a clinical instructor for New York Chiropractic College part-time. And the last couple of years of my practice, I worked as an assistant clinical professor for the chiropractic program at Duville College. I want you to keep an open mind, but not so open that your brains fall out. By that I mean, I want you to be critical thinkers. Please feel free to challenge anything that I say here today, and we'll all learn and benefit from that. Again, that's part of our mission with Spine Cloud International, is that we have a forum where providers can share information, share best practices, and share forms and anything that's going to help them improve the quality of their care. I'll begin this presentation by talking a little bit about the problem with spine care. Why is it an issue, and why is it important for us to be spending time with this? The biggest problem is around costs, and we can see from this graph that the costs have been rising exponentially. It has leveled off a little bit since 2007, but it is still increasing. And the blue is direct costs, those associated with paying for the care. The red is indirect costs, those associated with disability and impairment. You might expect that with these radical increases in the costs for paying for care, you might be getting better outcomes. But the red graph actually shows us that outcomes are worse. There is rising disability and impairment associated with spine pain, to the tune now of roughly $90 billion per year in the United States for each of these. as you can see on the right side of the slide, opiates, fusion surgery, advanced imaging, and epidural steroid injections are all going up rapidly in terms of their use without showing improvement in outcomes relative to that increased utilization. Another big problem is identified by Haldeman Desjardins is the supermarket approach to spine care. They identified well over 200 different treatment options. Providers are greatly confused by this. Just imagine how much the patients are confused by this lack of our standardization. Another big problem identified by Jack Wenberg at Dartmouth is the wide variation in care that can be geographic, by specialty, even within specialties, we'll see variation. This is a graph of the variation rate of spine fusion surgery. The dark blue is twice the national average. The dark green is half the national average. Intuitively, you might have suspected that New York and California were most of the spine surgery was done, but actually they both have pockets where it's only half the national average. The western states, Colorado, Wyoming, Nevada, those states are doing twice the national average in spine surgery. There are a lot of reasons why this occurs. The most common that people give is that it's because of cost. People greedy trying to make money, and that doesn't seem to be the case as much as other variables such as where the surgeon was trained, where they did their fellowship, where they did their residency and or fellowship will greatly determine how low their threshold is for identifying patients who need spine surgery. So if you were trained in one of these Western states where spine surgery is twice the national average, that's going to be the way you'll typically practice. Another big problem is identified by John Maffei is guideline discordant care. What we know from guidelines is that there should be more non-steroidal, this is by medical practitioners, more non-steroidal anti-inflammatory drugs used and fewer narcotics, muscle relaxants, Neurontin, specialty referrals, advanced imaging studies. And what you can see from this graph by the dark blue, which was done in 1997, and the light blue done in 2010, is that the care is actually discordant to what the guidelines are recommending. Instead of more NSAIDs, providers are prescribing fewer. Instead of fewer narcotics, they're prescribing more. Instead of fewer specialty referrals and advanced imaging studies, providers are doing more. The providers that were utilized in this survey by Maffei were 50% general practitioners, that is primary care physicians, and 50% specialists who deal with spine care. Our goal, after identifying those problems, is move towards a model of value-driven care where we use the definition given by Porter and Lee in Harvard Business Review, and that is quality outcomes balanced by the cost to get those outcomes. And that's the actual way, the operational definition for how value is being defined. So when I was teaching quality improvement training through a chiropractic college, I would always begin my program by asking the providers, who here is a high quality provider? Who thinks they're giving high value care? And invariably everyone in the room would raise their hand, which is what I would expect. But then I would ask them this question: how do I, as an independent party, know that the quality of care you're administering is high, or that the value of the care you're giving is high? And what we're starting to see, some accountable care organizations, some physician hospital organizations are starting to measure the value of the care of their providers. They're actually looking at clinical outcomes, and then they're looking at how much it costs to get that clinical outcome. And there's a sweet spot for value, and that is great clinical outcomes at a fairly modest cost. Think about it, it's easier sometimes to put this in the framework of a car, so that a Bugatti Veyron is probably the highest quality car you can buy, but it comes at a hefty price tag. It costs $1 million, literally, to buy that car. if you remember, if you're old enough to remember the old Yugo, which was basically made out of paper mache. It was a horribly low quality at a very, very low cost. So again, it wasn't a good value. Instead, you look at a Ford Focus or a Toyota Prius. Those you're getting a very high quality at a reasonable cost. Well, it's now the same model is being applied to healthcare services. Another goal is to have coordinated care. There's a wonderful article by the surgeon at Harvard, Atul Gawande, where he uses the metaphor of pit crews, and that is, instead of all healthcare providers functioning like cowboys out riding the plains and making their own decisions, we need to learn to work together where everybody knows their roles and they can do them effectively and efficiently. Another goal we have is to focus on the patient. When we first started writing our best practice care pathway as our consulting company, Spine Care Partners, I was making a presentation to a chief of neurosurgery of a large academic medical institution, and he said, "John, I've looked at these spine pathways for a long time now, and none of them seem to work. What makes you think yours is any different?" And I said, "That's easy. And it's the way we devised the pathway." And quite literally, when we defined our best practice care pathway, we built it around a patient. We put a patient in the center, and we devised the best practice care pathway based on best available evidence around the patient. Only then did we say, now, which providers can deliver those services in an effective and an efficient way? And typically, the way a spine center is developed is they say, well, we have a surgeon, we have a physiotherapist, we have a rheumatologist, we have a social worker, let's make a spine center. And that's why they don't succeed and why they aren't sustainable. Another goal of our model is that the care is evidence-based, as Sackett has defined it. It includes clinical expertise, patient values, and research evidence. And as this Venn diagram suggests, the sweet spot is the intersection of these three variables. There is a little caveat to clinical expertise, and the caveat is that the expertise is the ability of the provider to translate evidence into practice. Therefore, someone in practice for a year can have the same clinical expertise as someone who's been in practice for 15 years, if they are able to take that evidence and translate it into best practice. We do find a problem, as has been suggested by Mafi. This is the hierarchy of evidence. The anecdote is just your personal experience. Then evidence is when randomized controlled trials, cohort studies are all put together. Often that evidence is then organized into a full-fledged guideline for best practice. And that information is then often put into algorithmic format, whereby it's a flowchart for how people are practicing. What we know then is the status quo. By the way, for those interested in trivia, there was a late 60s rock band, the Status Quo, and this is their album cover. What we've learned about guidelines and algorithms is that many of the guidelines don't even follow all the recommendations by the Institute of Medicine for guidelines. Many of the guidelines also have a conflict of interest by the people who have written the guidelines. Often there's a financial conflict. And then we know from Mafi's study that practitioners typically, even if they know the information, don't translate it into clinical practice. So how do we overcome that? We think there are two great ways to overcome those obstacles. How do you cross this chasm from best evidence into clinical practice? I'm going to start right now by giving you all a little bit of a poll. I'm going to ask you to please look at this and pick what you imagine to be the most important of a best practice care pathway. Which of these four would you think might be the most important? And then I'm going to, when we move on after you've each had an opportunity to answer here, I will tell you what we think is the most important part. So is it coordination, enhancing communication, focusing on the first touch, administrative support? By the way, these are all variables that have been identified as being important to a best practice care pathway. So I'll just let you each have a little bit more time. And again, I will refer you back to that question section on your webinar toolbar, that if you have any questions as we go along or any technical glitches, please do type them in there and I'll be able to see them. Great. Excellent. 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 Just another couple seconds and we'll close this. All right. All right, great. It looks like just about everybody's had an opportunity. So I'm going to close it and I'm going to share the results with you. So interesting. 36% coordination of care, 45% enhanced communication, 18% focus on first touch, and nobody picked administrative support. That's interesting. This morning, about a third picked administrative support. All right, let me hide these results, and now I'm going to tell you what I think may be the most important part. These are the components that Forney identified as being part of a best practice care pathway. And just as a quick anecdote, Forney did a literature review and identified articles. He picked out 13 articles that had said they were about a best practice care pathway for spine. And then he used these criteria to rate the articles to see if they actually included each of these components and therefore were fitting the definition of a best practice care pathway. He only found 2 pathways that fit the published pathways that fit the definition. The first was his own. He's part of a group with Hamilton Hall up in Canada. The only other one that he identified as fitting the definition was the article that I co-authored with Brian Justice, Mike Snyder, and Ian Paskowski about the pathway at Beth Israel Deaconess Hospital in Plymouth that we published in 2011. So these are the components of a pathway: the classification system, coordination of care, enhanced communication. It follows the continuum of care. That is, rather than being silo-based, as Atul Gawande talked about, it follows the entire continuum of care. That there is continued monitoring of both the process involved with care and the outcomes of care, that it focuses on the patient's point of entry into the system, and that there is allocation of resources, that there is administrative support to make sure that it's sustainable. We would argue that the most important variable here is actually focusing on the patient's point of entry into the system. And the reason is quite simple, and that is if you don't manage the patient at the front end of care, then the terrible cascade can occur. And we know, we've all seen that in clinical practice. The patient who goes to their family practitioner typically with back pain, who maybe is given a medication, sent home, they come back with continued care, they might be switched over to now a narcotic medication, referred for some therapy which may or may not work. If they do end up back in the primary care provider's office, by this point they're probably going to get an advanced imaging study. The advanced imaging study, because of the high false positive rate, is probably going to show something where they're going to either be referred for an injection and or a surgical consultation. If they happen to be in one of those Western states where the threshold for doing surgery is so low, they very well may end up with spine surgery, even for local back pain with no radiation. So that terrible cascade can be prevented if the first touch with that patient is managed appropriately. And that's the second component of the solution to the spine problem, and that is utilizing someone who can effectively and efficiently manage the vast majority of spine patients. We refer to that as the primary spine provider. I just want to make sure that this handout, so what you should all be getting as a handout is a link to the article on chiro and manual therapies by Murphy, Paskowski, Justice, Schneider, and Pearl, I believe. The reason I gave you the link and not the actual article, it's an open access article, is it helps the authors the more people actually go to the journal and click on the article. It helps them identify how much it's actually being utilized and accessed. If you didn't get that handout through the webinar, let me know and I'll make sure I email that over to you. This idea is not new, nor is it from us. It really was developed by Dr. Scott Haldeman. Scott is a South African. His father was a practicing chiropractor. That prompted Scott to come to the United States and attend Palmer College of Chiropractic. He then continued his education to get a PhD in the neurosciences and an MD degree, and is now a practicing neurologist on the West Coast in the US, still lecturing around the world. If you haven't read his biography by Reed Phillips, I highly recommend it. It's an incredible historical account of the chiropractic profession and Scott's journey through it. The last chapter in the book is actually autobiographical. It's by Scott himself, and he talks about the opportunity that the chiropractic profession functioning in this primary spine practitioner role really provides us with. There is a problem we face as a chiropractic profession, and that is there's a bit of an enigma around our profession. We score lowest on scales of public trust, but we score highest on scales of patient satisfaction. Our utilization has never varied much from 8% in the past 50 years that it's been looked at. However, if you look at a specific condition, about a third of low back pain patients are using chiropractors as the first touch provider. And in fact, if you have the opportunity to meet and talk to some spine specialists, most notably surgeons or injection providers, they're often awestruck by the fact that chiropractors see 35% of spine pain as the first touch provider. Once they hear that, they're very interested often in partnering with chiropractors. They know that about 40 to 50% of spine pain goes to a primary care physician as the first touch. What they don't often know is that a third of patients are going to chiropractors as the first touch provider. So in spite of that enigma we have around our profession, it is a great opportunity for our profession. So how can you demonstrate value, coordination of care, evidence-based care, all in an environment where cost is such an important issue? We think it's embracing the role of the primary spine practitioner. And this is the actual article that I sent you the link to. It's on chiropractic and manual therapies, and it is an open access article. And I'll just talk for a little bit now about the actual skill set of the primary spine practitioner. We feel, much to the chagrin of some people, that this is a skill set defined, it is defined by, the definition of a primary spine practitioner is defined by a skill set, not by a degree. And that's part of why Dr. Haldeman and within our profession, Michael Schneider, have really emphasized to us that this is an opportunity for our profession. And if we don't embrace it, somebody else is bound to. So let's take just a very quick survey here. And I'm going to ask you about this skill set of the primary spine provider. Of the following four, the ability to diagnose, ability to order imaging, education of stakeholders, and exercise rehabilitation services, which do you think might be the most important skill for a PSP to enhance? Because we already have, as providers, we have each of these skills. Which ones would we really want to enhance? Great, great. And then we're going to share these results. I'll give just another couple of moments for everybody to respond here. and then I'll actually go through the skills, the main skills that we've defined that help define a primary spine provider. All right, great, 100% have voted, so I'm going to close this and share the results. As I expected and as occurred when I previously gave this webinar this morning, the majority opted for diagnosis as the most important skill, and I'm very happy to see a third of you said education of all stakeholders, and I'm thrilled that nobody picked ordering imaging, because that's a skill that needs to be really utilized only when it's appropriate. So I'm not surprised very much by the results here. Great, let me hide this and go back now to our presentation. Great, these are some of the skills. Certainly differential diagnosis is a very important one. By the way, the skill that we feel is most in need of enhancement is education of all stakeholders. We think most of the providers, certainly chiropractors, are pretty well versed and skilled in differentially diagnosing these patients. And good evidence for that is the low malpractice that is around the idea of misdiagnoses with spine pain. Chiropractors, by and large, tend to do quite a good job. It's typically not an error of omission relative to spine pain. Also, the ability to do a biopsychosocial assessment. We all tend to be pretty darn good at the biological assessment, coming up with that differential diagnosis, but we often neglect the psychosocial assessment, the ability to define psychological and sociological issues that are important to either the perpetuation of the patient's pain or sometimes even the cause. The second component of diagnosis is to take that diagnosis, not to just come up with an ICD code, but to actually be able to stratify this patient into a subgroup that will help to direct care. The ability to apply evidence-based treatments. These are not an all-inclusive list, but just some of the top skills that we know have a good evidence base behind them. Manipulation and manual therapy, McKenzie's protocol, neuromobilization techniques, rehabilitation stabilization techniques, the ability to educate, motivate, and guide the patient are all important skills. The ability to teach self-care strategies is really important. Build self-efficacy with the patient. The ability to do motivational interviewing and identify those items that are really motivating to the patient or those items that are preventing the patient from engaging in a behavioral change. In spite of the fact that we don't provide those invasive procedures, we have to understand them so that we know when they're appropriate. Additionally, we need to follow up after those invasive procedures with care, often with exercise rehabilitation care, and educating the patient about everything from ergonomic issues to activities of daily living. We need to be a coordinator. We need to have the communication skills so that we can speak to all the stakeholders and educate them as to what the most important components to value-based care are. We have to start thinking of spine pain as a public health issue, because it is. And it isn't just in the US, it actually is a global problem. It's a burden around the world. When organizations, anyone from the Global Burden of Disease to organizations in the United States, have identified the most important conditions that they should be working at managing, they typically put cardiovascular disease and stroke, diabetes, and back pain as the top 3 or 4. And you die from the first two, cardiovascular disease and stroke and diabetes. You don't die from back pain, but it is such an enormous burden to society that everybody is looking for ways at managing it better. The primary spine provider also needs to have the skills to manage disability issues, whether they are stay at work or return to work. They need to know some of the skills associated with motivational interviewing, avoid using language that creates iatrogenic disability, and they need to be able to educate the patient about self-efficacy and home care. They also need to follow the patient across the continuum of care, even utilizing something like a text message or an email that will help remind the patient to continue with their home exercise program. What I want to make clear too is that this primary spine provider program is not about surgery. It's not about chiropractic, even though it involves chiropractors. It is not about physical therapy. It is not about medications. It isn't even about cost, as important that is with care. It is about a patient-centered, best evidence, relationship-centered, shared decision-making, diagnostic, and treatment approach. The relationship component is that it isn't just about the patient. It's about the relationship between the patient and the provider. We know the spine problem, as broad as it is in desperate need of a solution. And you might ask, why are chiropractors functioning as primary spine practitioners so well suited to help solve this problem? It's because it's the skill set we were trained in by and large. You're helping to solve a it's actually $200 billion societal problem in the United States alone. It is the kind of services we're already reimbursed by, and the big component for me is it's the identity the public already knows us as. There is a study that was done by McGregor, no matter what the chiropractic providers said their practice was about, the majority of their patients were there for spine pain. As noted by some research by Nadine Foster, some 35% of back pain patients are using chiropractors as the first touch provider. The 45% comes from some data from our own experience, which we have not yet published. Our relationship with a large medical payer in New York State has shown us that some 40 to 45% of spine pain patients are going to chiropractors as the first touch provider. And also we score so highly on patient satisfaction, particularly around a condition like back pain. Great. Now, let me jump over to the questions section and open this up now to any questions you might have. I'm going to start with a question that came up this morning, and it was particularly about the University of Pittsburgh's program on the primary spine provider. We actually have a relationship with the University of Pittsburgh. One of my business partners in this venture, Don Murphy, is actually working directly with them and starting the program there. That program will be a full 100-hour certification program that the University of Pittsburgh will give. It's going to be 36 hours of face-to-face training, 64 hours of online learning, followed by an examination, and then a certification as a primary spine practitioner. What we don't fully know yet, and we're working towards, is what that's going to mean practically. And by that I mean, will there be opportunities for someone who is certified as a primary spine practitioner? And we know that there will be, we just don't know the extent of it. And an example of that is my consulting company, Spine Care Partners, has partnered with a physician hospital organization in the state of Michigan. And they wanted to sign up chiropractors, but they wanted the chiropractors to have training in this primary spine practitioner role. Well, we do have a 24-hour program, which we do face-to-face for a client, but we have now videotaped, and it will be on our Spine Cloud website. And so we'll be offering that. It is not a certification program, and it's going to be just a certificate of attendance, but it will provide an enhancement of many of these skills associated with functioning as a primary spine practitioner. So we don't know how, if at all, that online 24 hours we're offering on Spine Cloud International, www.spinecloud.org, will connect to the University of Pittsburgh program, but we're trying to figure that out right now. But right now it's not linked to it or connected to it. By the way, the cost of the University of Pittsburgh 100-hour program is somewhere in the vicinity of about $4,000 US. The platform that we have developed, SpineCloud International, is, as I mentioned, going to be a digital world for spine care, where there will be webinars, there will be online, videotaped online seminar programs. There will be the opportunity to exchange forms. We're going to focus on the clinical aspect of practice, but there will be a section on the business aspect of practice, everything from marketing your practice to communicating with other providers or other groups. So we're really going to be moving forward with adding more and more content to our SpineCloud site. And these webinars, these live webinars, will be recorded and placed on the SpineCloud site so that they can be accessed at any point in the future. Great. Any other questions anybody would like to ask? Great. Hopefully, oh, great. Now, first question came in, is Medicare a hurdle in the United States relative to this care? It is, partially. It is a bit of a hurdle because, for two reasons. The limited coverage for services for a chiropractor, and secondly, as many of the systems are, they aren't yet rewarding quality of care. If we can get a group like Medicare to start actually rewarding value-based care for our profession, they're starting to do it in the medical groups where there is actually, up to this point, it's been more of penalty for not following a process. But now they're starting to shift it towards rewarding people for actually following the process. So with Medicare, it is a bit of a challenge because our coverage is so limited for our services. We're not quite sure how quickly that can be overcome. The American Chiropractic Association, I assure you, as a member and as serving on 2 committees with them, is working diligently to try to change the nature of Medicare coverage for chiropractic services. Great. Can you briefly, talk about PQRS and what it entails? Yeah, the Physician Quality Reporting System, which is a Medicare project for reporting on the quality of your care, so to speak, has actually been changed, and it's no longer the PQRS. It's now referred to as MEPS, Medical Expenditure Panel Survey, I believe is what it's using, and they've changed their criteria for who is participating in it. Previously, chiropractors were required to participate in it, or they would penalize you by withholding some of your reimbursement. However, they've established now a utilization standard, which I don't have at my fingertips, but it's quite high. So unless you have a really substantial Medicare practice, I would guess in the upwards of 30 to 50% of your practice is Medicare, the PQRS, what is now MEPS, will not apply to you anymore. You do not have to do the reporting. There will be no penalty for not reporting. It's quite a substantial number. I believe from a dollar standpoint, if you collect $90,000 a year on Medicare alone, then you have to report. But again, given how low the reimbursement is, they only reimburse one service, 98940, 4142. It's not likely to reach those numbers. There was another question about the PSP. skill set? What practical steps can we take to grow in educating our patients and other stakeholders in the spine care continuum? Yeah, well, I'll tell you, one of the components of SpineCloud, as I mentioned, is related to the business of functioning in the primary spine practitioner role. So you can use the clinical part of it to really make sure that you're up on the literature, but then using the business aspect of it to go out and market yourself to self-insured employer groups, to physician groups. The last consulting job I just did for Spine Care Partners was to with a group of 9 neurosurgeons who hired our company to come in and help them put a primary spine provider directly in their practice, because they saw that moving towards a value-based model of care was going to be in their best interest. And they wanted to keep the patients who didn't need surgery within their footprint. And by having a primary spine practitioner as one of their staff members, they were able to accomplish that. So if you can get out and speak to these groups, anywhere from a physician group to a self-insured employer group, to the public at large, to senior citizen groups, and start to talk about this new model of care where you're going to help them manage their condition before all this other stuff happens, I think it's going to be extremely well received. SpineCloud International, spinecloud.org, will be offering a variety of resources and support materials that you can utilize to reach those goals. What is the cost of the SpineCloud program? Yeah, it's going to be relatively inexpensive. It'll be probably about $125 US per 12 hours. Because there's a 12 hours on cervical spine and 12 hours on lumbar spine. So to take both of them online with us won't cost any more than $250 US. Will SpineCloud membership offer forms and resources to train us to reach out? Yes, as I mentioned, there are 2 big components to what we'll be offering: clinical enhancement components and running your business enhancement components, all done in a very patient-centered, evidence-based model of care. Our goal, again, is to help you demonstrate the value of your services. I think if there's one thing that we really need to help emphasize within our profession is that we're a high-value service. We just need to get that message out. And once people start to understand that, they start to really embrace what we're doing. And when we can start immediately, I would encourage you to go to spinecloud.org and sign up as a member. And we are continually building that content, and we will be offering these webinars, as I mentioned, on a once-a-month basis. We'll be doing podcasts. We will be offering resources. We'll have forums for sharing information among the different members. And as I mentioned, both clinical and business training programs. Great, that's just about 45 minutes, which was our goal here today. You should all have my email address, john.ventura@spinecarepartners.com. And please do connect with us through spinecloud.org. And we really look forward to your participation and helping to serve you as best we can so that we can all demonstrate the value of our services and help patients with spine-related disorders. So thank you all very, very much. And I look forward to meeting with you all again and connecting with you all in the future. Thanks so much.